Good afternoon, everyone, and good morning to those of you who are joining us from the West Coast. My name is Alexa Eggleston, and I am the Substance Abuse and Addiction Project Director for the Council of State Governments Justice Center. I want to thank everyone for joining the National Reentry Resource Center's webinar on innovations in substance abuse treatment, continuing care, and medication-assisted treatment for the criminal justice population. Today, we are happy to be convening this webinar in partnership with the Substance Abuse and Mental Health Services Administration's Addiction Technology Transfer Center. Today's event is part of a webinar series that the National Reentry Resource Center is sponsoring that focuses on best practices for working with individuals with substance use and mental health disorders who are involved in the criminal justice system. Please be on the lookout for future webinar announcements. Today, we are joined by Philip Barber, who is the Staff Development and Training Coordinator with TASC, Treatment Alternatives for Safe Communities, and Ron Jackson, who is the Executive Director of Evergreen Treatment Services. Philip Barber joined TASC in 1991. Mr. Barber is currently Staff Development and Training Coordinator for TASC and a registered trainer with the Great Lakes Addiction Technology Transfer Center, which is part of a national network of centers sponsored by the Substance Abuse and Mental Health Services Administration. Mr. Barber has provided training throughout the United States on numerous topics, including clinical reentry management, criminal thinking, motivational interviewing, and many other related subjects. Mr. Barber's expertise is shaped not only by his professional experiences, but also by the fact that he once came through the treatment and criminal justice systems, which he now helps to improve. Ron Jackson has been a clinician, administrator, educator, researcher, and consultant in the field of addiction treatment since 1972. He is the Executive Director of Evergreen Treatment Services, a private nonprofit organization that provides outpatient opioid treatment to more than 1,500 patients in clinics in Seattle and Olympia, Washington. Mr. Jackson is currently a co-principal investigator for the National Institute on Drug Abuse's Clinical Trials Network and is an affiliate professor at the University of Washington School of Social Work. He has extensive experience working with special populations and developing local and national linkages, networks, and collaboratives. There will be a question and answer session at the end of the presentations. To ask a question, please type your question into the Q&A panel on the bottom right-hand corner of your screen. Please feel free to ask questions throughout the webinar, and then we will answer them at the end after the presenters have finished with their presentations. We will do our very best to answer your questions, but please understand that this is a very large webinar. There are almost 400 people on the line right now, so your question may not get answered. If that occurs, please feel free to contact us at the National Reentry Resource Center afterwards or the presenters, and we will do our best to answer your question. If you encounter technical or audio problems during the webinar, please call WebEx Technical Support at 1-866-229-3239. We understand that there are some technical issues you may not be able to resolve in time to participate in the webinar. For this reason, we are recording the event and we'll be posting the recording on our website within a few days, if not today. The URL for our website is www.nationalreentryresourcecenter.org. We really appreciate Mr. Barber and Mr. Jackson taking time out of their busy schedules to be with us today. Before we hear from Mr. Barber, who will discuss recovery-oriented systems of care, and Mr. Jackson, who will discuss medication-assisted treatment, I would like to turn it over to Ms. Hagel, the Director of the Northeast ATTC, who will begin the presentation.
Thank you, Alexa. I just want to take one moment to thank the National Reentry Resource Center staff for inviting the Addiction Technology Transfer Centers to participate in your webinar series. And I want to invite you to visit the ATTC region. As you see on your screen, the Addiction Technology Transfer Centers are funded by the Substance Abuse Mental Health Services Administration, SAMHSA, and we are a national network. So that means for you all today, everybody on this webinar actually has an ATTC that is assigned to your state. So if you visit our website, the Addiction Technology, the ATTCnetwork.org, which you can see the URL on your slide, and you click on Find a Regional Center, you'll see this interactive map, and you can click on your state. Say you're in Texas, then you'd be affiliated with the Gulf Coast ATTC. And once there, you'll find a plethora of resources that fit our mission, which our mission is to serve multidisciplinary professions such as yourselves who encounter people who are in addictions treatment and who need recovery services. And so we engage in a lot of training and technical assistance activities that you would find relevant not only to your state and your populations, but to other services that you might be looking into for your clients. So we invite you to visit the ATTC network. It's on one of the slides at the end of the session. You can get more resources and information. And then you'll be connected to the larger ATTC. And this is the strength of our region, is that we're able to tie into state resources and then through our national coordinating office network into all 14 regional centers across the United States. And that is exactly how we acquired the expertise of Mr. Philip Barber and Ron Jackson. And I want to say thank you to the other coordinating centers, the Great Lakes ATTC and the Northwest Frontier ATTC, for sending these experts to this webinar today. So I will turn it over to Philip and hope you guys will visit our website.
Well, thank you both, Holly and Alexa, for that fabulous introduction. And welcome everyone to this webinar. Part one of our presentation today is covering recovery-oriented systems of care. You'll hear me refer to this as ROSC. It's also kind of framed in recovery management, which is nothing new, but it's certainly gaining a lot of interest across the country in terms of how to look at addiction treatment. So we're going to go through my presentation around that, and then Ron's going to come in after with medicated-assisted treatment. So let's talk about recovery for just a second here. Recovery from alcohol and drug problems is a process of change through which an individual achieves abstinence and improved health, wellness, and quality of life. We wanted to kind of give it a working definition. There are some conceptual and language clarity issues here. As I mentioned, recovery management is a philosophical framework for organizing addiction treatment and recovery support services across the stages of both pre-recovery identification and engagement, which often, if you want to kind of parallel this to the current system, that's basically treatment. And then recovery initiatives and stabilization, which also occurs in treatment. But the newer concept is the long-term recovery management and quality of life issues that come with that. That definition is from Mr. William White. He's one of the national experts on recovery management, probably one of the early thinkers or early adopters of this philosophy around treatment. So in a recovery-oriented system of care, or ROSC, it's a coordinated effort between your community-based services, supports the persons that builds on the strength and resilience of individuals. And it is a person-centered activity, as I'll illustrate in a few slides. Communities need to be very involved in this in order to achieve abstinence and improve health and wellness. And then the quality of life issues for those with or at risk for alcohol and drug problems, all of that becomes part of a recovery-oriented system of care. You know, in the past, over the years, when you go into treatment, go in for a specific period of time, you get some education, they feed you, you put on a few pounds, and, you know, you're released back to the community, and hopefully you'll go to meetings, and, you know, very little follow-up with that. However, with recovery-oriented systems of care, we want to engage everyone that's involved with that person who's going through the recovery process. In this next slide here, what this recovery management model does is it moves away from the acute care, which is, you know, traditional treatment where you're, you know, trying to stabilize somebody, you're engaging them into the treatment process. But, you know, a 28-day program or a 6-month program, or however long the treatment lasts, basically is centered around an acute care model. Just like you broke your arm, they put a cast on it, send you home, and, you know, you're healed. Well, we know that to be different when it comes to addiction. recovery management is centered around a lifelong process where that person is going to have to manage their disease of addiction, not only just through treatment, but after they get out of treatment and even after they've been abstinent for quite some time. It's the same type of principle as having, say, diabetes or high blood pressure. You're going to have to manage this disease for the rest of your life. A couple of elements that I want to make clear to you are the values underlying ROSC and some operational elements of ROSC. And this kind of challenges the thinking around traditional treatment and treatment approaches. As I mentioned before, ROSC is person-centered. It's very much focused on the fact that the individual is in control of their recovery. We know there are many pathways to recovery, not just traditional treatment, but peer-to-peer recovery support, faith-based community organizations, medicated assisted recovery, and probably a host of others. What ROSC does is it offers choices among a flexible menu of services and supports designed to meet each individual's specific needs. We work a lot with the criminal justice system, who quite often they don't warm up to the whole 12-step principle in the beginning. They feel a little bit ostracized from that community. So we want to try to make sure that they engage in some kind of peer support network. Here in our state, we use something called the Winner Circle and Inner Circle, which is an offender group, ex-offender group. It seems to be more engaging for them because they can come in and not only talk about their addiction problem, but the other issues that are going on in their life. So having these different roads to the recovery process is very important in the ROSC model. The other major factor in this are the significant others, the participation of family members, caregivers. ROSC acknowledges the role of all of these people, anyone is significant to that recovering person's life and process. You know, quite often those individuals also need support services as well. It's not unusual for family members to not quite understand the addiction process for the client or the patient, and often they need support as well. And ROSC recognizes that family members, caregivers, significant others, friends, other allies have their own needs and support services, not just the client. Another underlying value of ROSC is this individualized. You know, we always say that it's individualized, comprehensive services and support. They also recognize there are many pathways to recovery and promotes the philosophy of the individual choice. This is very important and can be a very important therapeutic tool in engaging and retaining someone in treatment, letting them know that their recovery is self-directed, that it's not just about some treatment plan or service plan that I drew up that you have to follow. So the individual choice is very, very important in the ROSC model. It offers a broad array of services to meet holistic needs of the individual. Those are designed to help support recovery across the lifespan. And with the understanding that needs and resources shift, people, you know, they do okay for a few months and maybe they start getting discouraged because they haven't found a job or something's not going right in the relationship. And we need to understand that through stages of change and those types of things, those resources are going to need to shift accordingly in order to continue to meet that client's needs. And that's throughout the course of the recovery process. Other values that are very important to this is community-based services and supports. In the ROSC, the situation that draws on the strengths and resilience and resources of the community. This is especially challenging for criminal justice populations because, you know, they've got criminal records now. So they've gone through treatment inside the walls. They come out. They're very encouraged about the recovery process. But then if you don't have a community that supports that recovery process, it's only going to be a matter of time before that individual gets discouraged. So it's very important that in community-based services and supports that you include professional and non-professional organizations such as community-based organizations, anything that could help with that day-to-day life stuff like food pantries or maybe housing programs or vocational programs, things like that, so that the patient gets the kind of support they need in order to just meet their daily needs. Then you have recovery community organizations, all of the 12-step model programs, the inner circle, winner circle that you may have in your community. Faith-based organizations have been very big in terms of filling gaps. This is especially true when you get into rural areas where there may not be a lot of formalized treatment or support available. Faith-based organizations, churches, often do an excellent job at filling that gap, and they need to be engaged. Civic organizations, any kind of organization that is willing to give a person a second chance. Again, the criminal justice population is kind of a unique animal. You know, a lot of people don't quite understand that people actually make mistakes in life, and once they paid the price, that they should be given the opportunity to get their lives back together. And certainly schools and other vocational opportunities that a person could access so that they could become self-sufficient. All of those underlying values of ROSC are very, very important. When you get into operationalizing recovery-oriented systems of care, the continuity of services and support is very, very important. One of the challenges often when people are being released from prison is that there's not a smooth handoff. You know, somebody, the Department of Corrections has information that needs to be passed on to the community. There may need to be follow-up with regard to treatment and aftercare. And often those kinds of infrastructures don't work very well for all kinds of reasons. Technology reasons, compliance issues, confidentiality. A lot of bureaucratic red tape sometimes can get in the way of that. However, from an operational standpoint, it's essential that that seamless connection be established between service providers and corrections departments, including parole agents, probation officers, that type of thing, so that everyone's on the same page about what the client's going to need. Another operational element is service quality and responsivity. There's been this huge discussion, or not huge discussion, but certainly an important discussion around criminogenic factors, trauma, a number of things family-focused, what's appropriate for a person in their stage of life and the stage of recovery. And quite often, you know, those things get assessed using a variety of different tools and everything and you know, never really acted on or never really matched up to what the client needs. So the service quality and responsiveness is very important. If you have a client who is worried about where am I going to spend the night tomorrow night, and you're talking about, you know, DSM-IV criteria, you're not going to reach that client. You need to be able to talk to them about what's going on in their life. If they have been a victim of trauma and they're still suffering from that trauma, that the focus be on helping them deal with that so that they feel engaged and they feel that they're working with a system that really cares about what's going to happen next to them, rather than just kind of move down the treatment continuum according to whatever procedures you have. So service quality and responsiveness is very important. Another operational element of ROSC is the recovery community and peer involvement. This can take a variety of different shapes. Traditionally, you have 12-step programs out there, AA, NA, CA. Non-traditional ones are things like the winner circles, other types of peer-to-peer support services, like, again, through faith-based organizations or other groups, you know, who have pro-social activities that, you know, the patient can get involved in to help fill up their time. And then people in recovery and their family members, caregivers, and other, you know, significant others, they are included as part of the decision-making process for the client in recovery. And quite often that's how a lot of people end up in treatment anyway, trying to maybe satisfy a spouse or significant other, and it's really not their own decision. But one of the operational elements of ROSC is that all of these individuals who are part of that patient's life be a part of the decision-making process with that patient so that they can compromise maybe or even come up with alternatives. You know, it's not unusual for a client to want to do a lot, or at least say they want to do a lot, but then only act on very little. And we need to understand how that, you know, why that's happening. So peer-to-peer recovery support services and those other significant others in that patient's life are very important in terms of being part of the treatment team or treatment process for that person. operational elements of RASC that have really moved us along are the outcomes. They're driven for the individual. Now, when we talk about outcomes, that always gives the impression that there's going to be an end to something. When in fact, outcomes in a RASC model refer more to incremental success. Again, recovery is a lifelong process, and obviously the only time that's going to end is when a person stops living. But throughout their life, the different outcomes that they could have based on where they were 2 years ago, 3 years ago, 4 years ago, that's the kind of outcomes we talk about. And we talk about incremental success. They may not be able to accomplish everything on the treatment plan when you want them to, but if they have made some inroads and progress, it's very important that that be recognized as an outcome, a positive outcome for that individual, and also for the system. You know, quite often, especially where treatment is concerned, if somebody stayed the 30 days and they were successfully completed from treatment, you know, that was considered a favorable outcome. Well, as we know, that's really where the work begins. When they finally get out of treatment and they're back home and they're back in their natural environment, what follow-up and what data is being collected then in terms of a person staying in recovery. So this outcome-driven approach to RASC is very important, not only while they're in treatment, but certainly for a period of time while they're, you know, after they've finished treatment. And again, it's not just for the individual, it's also for the system. That's how you'll know whether or not what you're doing for your clients is actually working. Some strategies to help promote recovery-oriented systems of care. You need to have an assertive outreach and engagement process. Traditionally, when people seek out treatment, they'll call someplace, they'll be given a phone screening, maybe put on a waiting list, something like that. That will only last as long as you can respond to that person's needs. If you're able to get them in treatment in a reasonably short period of time, that's fine. But what about those people who are still sitting on the fence about it? Maybe they're in pre-contemplation, they know they got to do something, but unless you can reach out to them and try to continually engage them in the process of treatment, they may never enter treatment. So you need to be able to engage potential services for recipients through street and/or phone outreach. Be creative about this kind of thing. Peers and mentors during initial contact. Welcome centers work really well. Quite often when people go into treatment, just having somebody go in for the intake with them helps kind of ease their anxiety about it. And again, utilizing charismatic and engaging peers in the reception area, that's a very good thing to do. One of the things we do here at TASC, we have a greeter downstairs, very nice woman. Everybody comes in the building. She doesn't know what they're here for or anything, but it's almost like they came in for a massage as opposed to to see their case manager. It makes a big difference because people don't feel so intimidated by just coming into our office every day. And they can come in and they're greeted with a smile. They're greeted with somebody who really genuinely seems like they care what's going on with them. Other ways to do this is to build strong support linkages at all levels of care through peer-based recovery support. Again, having adequate knowledge and understanding which support groups are available in your areas is real important, because when a client decides finally says, okay, maybe I'll go to a meeting, worst thing you can do is not have a meeting guide and show them where they got to go or where they can go. So being very aware of what linkages are available and what services are in your area is also a good outreach and engagement strategy. Instill hope and increase expectations of positive treatment outcomes. This invites people to do storytelling sessions. I'm sure a lot of treatment programs every once in a while have a speaker come in. We do this at our county jails, at our various prisons where there are outreach workers from local 12-step communities to come in and tell their story. It's a very powerful engagement tool. Other strategies to promote engagement and retention is key. Now, this is kind of difficult, but you probably need to look at policies around administrative discharges. And this, can run the gamut. A lot of times people are discharged from treatment because they're not progressing fast enough. Doesn't mean they're not progressing, but, is this an opportunity to take a look at our own policies around administrative discharge and engagement? Maybe we didn't do enough for the client to keep them engaged. Rather than just write them off and say, oh, he wasn't serious about treatment, take a look at some of our own standard operating procedures around discharge. Did we do what we needed to do to reach out and keep that client engaged? Work with your criminal justice partners to develop graduated sanctions for relapse and or low participation. Now, there's a piece to this that is really missing. Not only were we talking about graduated sanctions, but you need a policy around incentives. This is especially important for people that are going through treatment inside and then they come out. Quite often, treatment does a lot of recognizing of positive behavior. They get certificates, that kind of thing. It's always a good idea that you can carry that conversation out to when they get in the community, where if a guy has stayed clean for 30 days, that maybe a case manager gives them a certificate, something like that. So incentives are very, very important, not only sanctions. Offer flexible service hours. Again, you know, most treatment programs have their hours, especially when you're into case management type things like that. But if you can offer hours that complement what the client is going through. Maybe they've gotten a job now and they don't get off till 5 o'clock. So perhaps our hours could be adjusted where I'm going to meet with him at 6:30 or something like that, and not be so rigid that, you know, to kind of put the client off and you're not really trying to meet them halfway. So offering flexible service hours is another good idea. And then provide case management services to address obstacles and focus on real life issues. One of the biggest challenges that we have with a lot of our clients is transportation. Even though I'm here in Chicago and we have a mass public transportation system, you know, getting a bus card sometimes can be very difficult if you haven't got any money in your pocket. And those things can't be ignored. It doesn't mean that we have to have a solution to everything, but certainly understand and be empathetic with the client and help them try to work through how can we deal with this problem as a team and not just leaving them out there to fend for themselves and that kind of stuff. So let's talk a little bit about self-direction. Professionals support people in making their own choices. Again, this is probably the foundation of recovery management or recovery-oriented systems of care, is making sure that the client knows and the professional knows that that client is in charge of their recovery. Even taking risk is supportive, even with failure is an option. Now, you've got to be careful with that with the criminal justice population, because they may be under supervision of somebody who has zero tolerance for mistakes. But where things can be tested, it's probably a good idea to let clients go ahead and say, you know what, okay, this is my idea. Let me try this. And when they see it's not working well, it becomes a lot easier to talk to them about what they need to be doing. When they feel they have the opportunity to test things out, as long as it's not going to hurt them. Goals and strategies are determined in partnership. I think we all know that. It's not just your plan, it's their plan, and they should have input on it. Services are person-centered, adapted to fit the needs and preferences of the individual. And menu of services should be available, not just one. Person's got to go to aftercare, should be presented with 2 or 3 different choices, or maybe even let them go out and pick a program for themselves, one that they feel comfortable with. Again, that creates a little ownership in the process that I made this choice for myself. Other strategies to promote individualized and comprehensive services. We have to be aware of co-occurring services. Many of our clients have multiple issues going on. Ron's going to talk about that a little later. And we need to be aware that that client may not only need substance abuse-only treatment, but they may need dual diagnosed treatment. Having a global and ongoing assessment process is important. Probably one of the most difficult things to continue to do is ongoing assessments, because it's always kind of tied to some kind of a tool. But in fact, your recovery plan and your constant updating and case management notes of working with that client is, in fact, an ongoing assessment. And we need to use that to shape any changes in the treatment process or the case management plan. And again, always have the client involved in that decision-making process. Want to develop a flexible menu of services and philosophy of choice around life skills groups. Other things that come to mind are finances, physical health, the kinds of information they're going to need in order to manage this thing beyond treatment. Because when it really comes down to it, once you get clean and sober, this is what recovery is all about. Another thing that gets underplayed a lot is the fact that people need to be happy in this process. Recreational and social opportunities and activities are extremely important in the recovery process because you have to remember, a lot of folks started getting high because life was boring. So now we're asking them to get into recovery. You know, there's going to be that thing in the back of their mind saying, oh, here we come with the boring thing again. So recreational social opportunities are very important in terms of keeping a person engaged in the recovery process. Recently, trauma-informed care is getting a lot of attention. Our clients go through a lot of stuff to get where they're at, and it's essential that the staff be in touch with that process, to be educated about it, that you have people, you know, who understand how trauma works and can help a client go through that. And trauma could be anything. It doesn't have to be violence. It can be, you know, the loss of a loved one. It could be, you know, the loss of personal possessions. In a way, that's a trauma for a lot of clients because they've got to rebuild their life. They've lost so much stuff. And then support employment opportunities. Again, this is much easier said than done because we have some employers who are just not very forgiving of criminal records. So it's always a good idea if you can engage the private sector in a recovery-oriented organization or network that says, hey, we'll give, you know, your guys a second shot. As long as they're doing what they're supposed to do, we can give them a job, give them job training. There are companies out there that do that. There are people, entrepreneurs, all kinds of opportunities out there. You just got to find out where they're at. Also, when we're talking about promoting individualized comprehensive services, if you have the ability to do it, provide services in a non-stigmatized setting. And by that I mean, you know, our case managers are out in the field a lot. They go visit clients in public places, even their homes, when they feel safe after, you know, they've gotten to know the client. Clients don't feel ashamed to go to a McDonald's and sit down for a half hour with their case manager, or maybe even to come to a public library. We actually have 2 churches in one of our areas that allow us to do our month-to-month groups. So being able to have services in an area where it's not a probation office or a parole office, it really helps get clients in the door. You know, they don't feel so intimidated by it. And then, of course, having services integrated with physical health. A lot of times, you know, our meetings with clients aren't necessarily about how's treatment going. We want to know how their diet is going because maybe we're aware that they have some health problems. These are the kinds of things that clients look for when they say, are you really trying to help me here? Even if we don't have the answers and that type of thing, being concerned enough to talk to them about their physical health and their mental health often really helps them, you know, stay on track with their recovery. And then there's mutually beneficial collaborations. What's going to be good for our clients is going to be good for our agency as well. So if we're working with clients and you know, we're getting more and more people successfully through treatment and case management, that certainly is beneficial to us as an agency as well. So, I mean, a person who does well, they're not only doing well for themselves, they're actually doing well for you know, this type of system as well. I want to make sure I'm getting through these in time to give Ron room for his presentation. I want to just briefly kind of point out a couple of these bullets, not all of them, but identifying and engaging everyone in this process that interacts with the client. And that could be anybody, you know, family members, coaches, again, peer-to-peer support, that type of thing. You want to utilize recovery coaches and peer support to help people develop or connect to a culture of recovery in their community. That's very important. A person has to be able to recover within their cultural context. Quite often, you know, lots of treatment systems and case management systems, you want to take a person out of that and say, okay, well, they go stay in a halfway house for 6 months, and then we'll let them go home. Well, the bottom line is at some point, they all want to go home. Once in a while, you have a client who does want to relocate and change everything about their life. But generally, the rule is, I want to go home. And they need to learn how to cope with recovery within their cultural context. So the sooner that we can help them make that adjustment, the better. And you want to utilize professionals and natural supports, things that they're going to feel comfortable with. If there are people in their lives that they easily can talk to, you want to engage them in the continuity of service and supports. The other things about service and supports that exist in the community that are not recreated in treatment. Probably the one thing that I think is a constant across all treatment organizations is they always encourage people to go to 12-step recovery when they get out. They'll take them to meetings, introduce them to the process and all that. Well, we don't need to recreate that wheel. In recovery-oriented systems of care, we should just continue to encourage that participation, but it's not like they have to start over. A lot of people come out of treatment or come out of prison-based treatment and they think they have to start over. Well, that's a mistake on the part of the existing system by thinking they have to start over. They've already started. And so we want to engage them and not recreate what's already been done in treatment. Let them continue on so that they feel they're making progress. The other things that are hard to address here, it's a challenge for probably everybody in this country, is addressing those hierarchical needs of housing, transportation, food, that kind of stuff. At a minimum, we need to seek out resources that can help that client address those issues, because if they can't get food or if they haven't got a decent place to live, it's not likely they're going to keep themselves engaged in the recovery process very long. Their survival instincts will kick in, and the next thing you know, they're headed for trouble. So we want to be cognizant of all of these things. The biggest message on this slide here is that the treatment is part of the recovery, but it's not equal to recovery. Treatment, is designed to be an intervention. It stops the act of use. We stabilize them. Again, kind of get them back to a reasonable state of health so that to prepare them for recovery. The goal of treatment is abstinence of symptoms. The goal of recovery is a holistic health plan or a health life. Everything needs to come into place in the recovery process. Treatment alone does not address other challenges such as family, employment, housing, etc. In recovery, that it becomes the number one concern, because after the drugs are gone, that's what you have to deal with is, how do I support my family? How do I find a job? Where am I going to live? Those are the kinds of things in a ROC model that gets the attention, it gets the focus. Recovery is different for each individual, and the social determinants of health needs to be addressed before the recovery process can move forward. If you have someone who is really beating themselves down and put themselves through the ringer, you've got to address those other issues that are going to allow them to move forward in the recovery process. When you talk about the other co-occurring disorders, other physical and psychological health problems that a person can have, if that stuff goes unaddressed, it's only a matter of time before they go back to self-medicating just so that they don't have to feel the pain. So in that recovery-oriented system of care model, we need to be able to address those issues consistently. Examples of recovery support services, I'm sure this is nothing new on this page here, but employment services and job training, case management, individual services and coordination. Case management is very important because after treatment, even with a person engaged in other types of recovery support, having someone skilled in case management can help them prioritize things, make sure they don't get detracted or distracted from the intended goal, to kind of get through things. Also, again, recognizing incremental success. Case management can be very, very helpful in that process. Relapse prevention. We hear this term all the time, but what does that really mean? And for some clients, it means walk around the block the other way this time. It doesn't have to be rocket science. But relapse prevention and knowing what ticks that client off, what the cues and triggers are, is going to be very important in that recovery process. There's certainly the other life issues around housing, child care, parental education, child development support services. All those things are examples of recovery support services. A few others, again, transportation to and from treatment, family, marriage counseling. Quite often, one of the number one causes for relapse is relationship issues. Not necessarily marriage counseling, but certainly relationship issues. what do you do about that? If you don't talk about it, nothing ever gets done. So that should be a big focus around the person's recovery, especially if they have a family and they're married and have children and all that kind of stuff, making sure that that's on solid ground. Again, peer-to-peer mentoring and coaching, self-help groups, including spiritual and faith-based groups. Linkage to institutional corrections agencies and community-based organizations. This holistic approach to recovery requires an effective collaboration between all those systems. Just a quick example, one of the things in Illinois that they did with their clinical reentry model was certain technical violations that parole agents used to have the authority to levy. It wasn't that they took those away, but like, for instance, a client that gets field tested, he's got a dirty drop. It used to be they could put the cuffs on him and violate their parole, instantly. Since then, in the last 5 years, they've instituted an intervention process where they actually contact one of our workers so that we can talk about getting them in the treatment first. Now, if they don't go, then the violation moves forward as it used to. But the idea of having a different type of intervention and collaboration with that other agency is very important to that client's recovery process. As we know, people stop using drugs. There's a high likelihood that there will be a relapse during that recovery process. When that happens, responding to it, as a punishment, that's not going to help matters. We need to find out why it happened and what we can do to keep it from happening again. Communication and case management are key to the recovery process. The results are more effective treatment and more efficient use of funds, because locking people back up just because they're using drugs costing everybody a lot of money, as you already know. And then lastly, just to touch on a couple of things, it's essential that any RRC model that you use evidence-based programs that should identify desired outcomes for offenders and include the means for measuring their progress. Again, I kind of glossed over it, but incremental success is very, very important to the process of recovery and recognizing that when it happens. The implementation of evidence-based practices results in an average decrease in crime of 10 to 20%, whereas programs that don't use evidence-based practices tend to see no decrease and even a slight increase in crime. Interventions that follow evidence-based practices can achieve recidivism reductions of as much as 30%. That was the early data that we got from our Sheridan model here in Illinois, because we had linked it to recovery-oriented systems of care and clinical reentry work. So it does work. I mean, if you kind of change your thinking about this, it does make a difference. Lastly, the benefits of the criminal justice system obviously is going to increase your traction. If you have good numbers and things are really turning out differently, you're going to have more people interested in that route. It provides early intervention for first offenders and early diversion programs, increased access, finite capacity of treatment systems leads to a long waiting list. So the more systems you put in place by which you put that recovery process or recovery responsibility in the hands of the patient, the faster they're going to get through the process. So that kind of concludes my slides. I rushed through it, but as you can tell, time is running out. So, Ron, I do apologize if I've run over a little bit. I'm going to turn it over to Ron Jackson for part 2 of the presentation, and I want to thank you again.
No worries, Philip, and thanks for a comprehensive look at ROC. Hi, everybody, and the same thing that Philip just encountered, I'll probably encounter too, and that is I've got a lot of territory to cover, so you have the full slide set. If I'm going, you can download it from the website, so if I'm going quickly through some of the slides, I apologize in advance, but I want to get to the meat of the issue. So this part of the presentation, I'm going to cover all of the FDA-approved medications for alcohol and opioid dependence. I'm not going to include anything about nicotine dependence. I'm also not going to cover any off-label use of various medications. And just so that you know, in case you didn't, there aren't any FDA-approved medications for cocaine, methamphetamine, marijuana, or benzodiazepine dependence. As I launch into talking about medications for alcohol addiction, I want to remind all of us that we approach this treatment of addiction as addiction as a chronic medical disorder. By that I mean it's something that is a blend of probably genetics as well as behavioral and voluntary choice, a variety of different factors like other chronic medical diseases such as hypertension or diabetes, and that the role of medications is as a tool in the treatment process, and that treatment is really a process by which we teach people how to use the various tools, not only medications but behavioral change, cognitive change, etc., to learn how to manage their condition over time. None of these medications are curative of someone's addiction. They are simply management tools. So there are a variety of different ways to treat alcohol addiction. Some of the medications we're going to talk about actually reduce some of the post-acute withdrawal symptoms. Others block euphoria. And then last but not least, or actually first, is the medication that basically punishes the person for their use of alcohol by creating an unpleasant association. And by punish, I mean from a classic behavioral standpoint. So the oldest medication is known generically as disulfiram. Most of you know it by its trade name of Antabuse. It's been around for quite a long time now, about 60 years. And the big issue for prescribing Antabuse or disulfiram has to do with liver health. And I'll talk more about that in just a second. Here's the way that Antabuse works. What you see in front of you is the metabolic pathway for the metabolism of alcohol. Alcohol is basically a toxin that the body works hard to change to be a more tolerable and then an inert substance. And there are two steps to that. In the first step, alcohol is acted on by an enzyme called alcohol dehydrogenase, and the first metabolic pathway or the first metabolite of alcohol is acetaldehyde. Acetaldehyde is then neutralized, acted on by acetaldehyde dehydrogenase, and breaking it down into more inert substances. Antabuse works by inhibiting the manufacture of acetaldehyde dehydrogenase. And that means that acetaldehyde, which is actually a more toxic substance than alcohol, is free to float around in the bloodstream unchanged for a longer period of time. And that's what leads to the various symptoms you're going to see. Some of you may have heard of this phenomenon called the Asian flushing response, where some individuals of Asian genetic heritage have this sort of flushing response. It's basically the same thing. They just have a genetic inhibition or inability to produce sufficient acetaldehyde dehydrogenase. So you drink alcohol, acetaldehyde builds up in your bloodstream, and it sticks around for a while. Here are the sort of symptoms that people get. They're anywhere from unpleasant to downright nasty. Some people are more susceptible to this than others. Some people literally, if they splash on alcohol-based aftershave and they're taking Antabuse, they're going to get an Antabuse reaction. Other people can drink on top of it and have relatively mild symptoms. So please don't think that this is some sort of cure-all, that the person who is on Antabuse and consumes alcohol will have such an unpleasant experience that they'll discontinue drinking or never do it again. In fact, we see patients all the time who drink on top of it. So here are the various kinds of symptoms. The big thing about Antabuse is that it first of all takes a physician to look at a liver profile, a liver function test, to make sure that the person's liver is healthy enough. Here in my clinic, we have a number of people who, in addition to being opioid addicts, are also alcoholic. And only a small subset of those have sufficiently healthy livers in order for us to be able to even think about using Antabuse. And for our patients, the Antabuse decision is always voluntary. We say this is a tool that you can use. There are negative consequences and so forth and so on. You can see how long the Antabuse reaction lasts. You can see that you have to make sure that the person is alcohol-free before you ever induct them onto the Antabuse, which can be tricky for some individuals. Literally, some people can't abstain from alcohol long enough to ever be inducted onto onto antabuse, which would obviously be a contraindication. And then they also have to be warned about the use of other alcohol-based preparations. When it comes to the research about disulfiram, it has a modest effect size. It's certainly no silver bullet by any stretch of the imagination, but it will help reduce drinking in people who are motivated, and you literally, one of the biggest issue for disulfiram, obviously like most medications, is compliance. People that lose their motivation to abstain from alcohol often lose their motivation to continue to take disulfiram, stop taking it, and then return to drinking, and they don't get that antabuse reaction again. The newest medication to treat, that's been approved by the FDA, was been around in Europe for some years, to treat alcohol dependence is a camprosate, which goes by the trade name Camprol. It's been approved for the last 7 years, and it's used in abstinent individuals, and it really seems to do two things quite well. One is that it suppresses some of the post-acute withdrawal symptoms, and the other is that it seems to mitigate somewhat against craving. And there's no physiologic dependence on this medication either. I put this slide up here to help illustrate what goes on in the course of alcohol dependence. When we're walking around and we're not consuming alcohol, there's a balance between two neurotransmitter systems in our brain. The GABA, which is often the neurotransmitter that's associated with an inhibitory neurotransmitter, and it's associated with alleviation of anxiety. And then there's glutamate, which is an excitatory neurotransmitter. And when you consume alcohol, you kind of shift your system more to inhibition. That's why some people like it. It helps reduce social anxiety and so forth and so on. As you continue to consume alcohol, you get back to this adaptation place where the amount of alcohol that you're drinking is really not doing very much to inhibit GABA. It's kind of, there's this equilibrium that takes place. And when you stop drinking, once you have developed tolerance, the balance shifts to excitation, which is a glutamate-related phenomenon. And so it's thought you have the prolonged withdrawal syndrome. It's true for a lot of substances, but it's been particularly well studied in alcohol dependence. And so a camprosate probably increases the activity of GABA. So to help rebalance that equilibrium that you saw before. And so the withdrawal symptoms that you see in alcoholism are largely driven by this excitatory glutamate release, and glutamate also seems to be associated with the phenomenon of craving, which is why you want to have something to kind of rebalance this. It seems to be earlier on effective, a camprosate does, and it has a relatively modest effect size, but seems to be effective for some individuals. A recent medication is naltrexone. Some of you know it by its trade name Revia or Depade. I'm going to talk about it in the oral form first, and then I'll talk about the injectable sustained release form here in just a moment. Naltrexone was first developed as an opioid antagonist. By that I mean it is a drug that blocks opioid receptor sites inside the brain, and so you may be asking yourself, well, why would that be neurochemically effective for alcohol dependence? Well, it turns out that there are probably several factors that are going on, but as you see in this slide, by being an opioid receptor blockade, it also it diminishes the release of dopamine. It's a complicated thing, much beyond the scope of this quick summary to talk about, but it does seem to be effective. Some people get that kind of opioid/dopamine-related effect from alcohol, and this seems to be a medication that helps them resist the craving and not get the level of reinforcement from alcohol. So here's Dr. Tom McClellan, who was the former Deputy Director of the Office of National Drug Control Policy, many of you know of. is fond of saying that naltrexone is the best acting drug that nobody will take. And so getting people to take it and comply has been an issue, and he has done several studies looking at its effectiveness in criminal justice populations. This medication, naltrexone, is also FDA approved for opioid dependence, as is the extended-release injectable suspension that is known as Vivitrol. It has been approved for several years now. It is an injectable drug, as I mentioned earlier, and this gets right to the heart of the compliance issue, because once the person has been injected with this injectable naltrexone, they're going to have opioid blockade for the next month. There's no way to get it out of the body or anything else. There have been some adverse effects with people taking naltrexone, and so there is a warning that people who are on this injectable form of naltrexone need to be closely monitored for suicidal ideation, and etc. It's also true that since this is an opioid blocker medication, if the person is facing surgery, for example, or needs some other form of opioid-based analgesia, that there's going to have to be consideration by the treating clinician with regard to that. And here's the research about extended-release naltrexone. It seems to be well tolerated, and it seems to be effective for a lot of people, and it has a modest effect size. And what you see here is a greater reduction in the number of heavy drinking days, which is an important outcome. Okay. Now I'm going to move along and talk about medications for opioid addiction. We're probably moving into the more controversial section of this part of the presentation. So there are three ways to approach the treatment of opioid addiction from a medication standpoint. You can either use an agonist, which occupy the receptor sites fully and actually at some point form a blockade, or you can use partial agonists, which block the receptor site with a little bit more robustness, but it has less of a robust opioid effect. And then, as we just talked about with naltrexone, you can use antagonists, which block the opioid effect. So let's start with the agonists here. The first thing I want you to see is this little graph that kind of explains from a graphical standpoint the various kinds of opioid effect. You get a full opioid effect with methadone, you get a partial with buprenorphine, and you get a complete antagonist effect with naloxone. My analogy is a lock and key with this. If you think of a receptor site as the lock, a full agonist is exactly like a key that fits exactly in that lock. It goes in the lock, opens the door with full force all the way. A partial agonist is like a kind of a skeleton key that fits in the lock but only opens the door part of the way and with not as much force. And an antagonist is not unlike gum that you stick in the lock. It goes into that lock and blocks the lock from being occupied by a key, but it won't open the door at all. So that's the way to think about these three different techniques. So methadone has been around for a number of years. You're about 47 years now, and was the first medication that was used, I think, successfully to treat opioid dependence. Before methadone as a maintenance kind of drug, the modal way of treating opioid addiction was detoxification, and that led to poor outcomes because detoxified opioid addicts relapse relatively quickly. It's been controversial since its inception. You know, most people think you're going to give drugs to drug addicts. What's up with that? Why would you do that? Why would you give them the drug to which they have become addicted? Well, in an effort to try to address this controversy, the National Institutes of Health held what's called a consensus panel. It's basically a scientific study, not study actually, kind of like a review of the literature on various topics relating to health. And this particular question was, is there an effective medical treatment for opioid addiction? And if so, what might it be? You can see the details of how they went about this process. The third bullet I'd like to draw your attention to gives you an idea of the empirical support for the effectiveness of methadone treatment. Many people don't realize this, but not only is methadone the most evidence-based form of treatment for opioid dependence, it's actually the most evidence-based form of all drug addiction. There's just been an avalanche of literature science about this, and it's one of the interesting side effects of being controversial. It's been studied up one side and down the other. I want to draw your attention to one of the conclusions of the panel as reported in the Journal of the American Medical Association. You can see the site there. It says of the various treatments available, methadone maintenance treatment combined with attention to medical, psychiatric, and socioeconomic issues, as well as drug counseling, has the highest probability of being effective. It's important to see first of all, what this statement doesn't say. It doesn't say that it's universally effective, nor does it say that it's a medication alone strategy. It says quite clearly that it has to be combined with attention to these other issues, as well as coupled with drug counseling. As almost everybody in this phone call probably knows, being an opioid addict is often, most commonly, a proxy measure for having a lot of other life problems. There are untreated medical conditions. There's homelessness. There's relationship problems. There's legal issues. There's untreated psychiatric problems. All of those have to be attended to. Methadone is not going to get you housing. Methadone is not going to treat your neuropathic pain. Methadone is not going to do a variety of different things. It takes a lot more than just a medication. So I'll say a few words. I'm sure that some of the participants in this webinar encounter women who are opioid dependent and who are pregnant. Methadone is really the gold standard for treating opioid dependent pregnant women, simply because the risk to the fetus is much less. One of the major issues in the treatment of opioid addiction in pregnant women is this intrauterine or in utero abstinence syndrome. Everybody talks, as rightly they should, and be concerned about the neonatal abstinence syndrome. But if a woman is pregnant and opioid dependent and she goes into withdrawal, the baby is going into withdrawal too. And so you want to minimize that traumatic experience with the newborn, with the unborn. So that's why you put her on methadone treatment. There's data that suggests there's an increased risk of spontaneous abortion if detoxification is done in the first trimester, and an increased risk of stillbirth if done in the third trimester. Just a brief word about methadone and breastfeeding. The American Academy of Pediatrics actually has a position statement that says that unless it's otherwise contraindicated, the breastfeeding of a newly delivered pregnant woman on methadone is encouraged. So methadone is a full opioid agonist. The principal reason for using it is that it's orally effective and long-lasting. That's really why even if heroin were legal, I'd still be a proponent of methadone, because it's orally effective and longer-lasting, whereas heroin is not. And it works for a full day. You get full effect for a single day, and you have to be careful when you're inducting patients onto methadone because of the half-life. You have to basically start low and go relatively slowly to get the person to a stable dose. Rushing up the dose is not particularly advised. So I get this question a lot. So Ron, you've got all these patients on methadone. Aren't they still addicted? And what I say back is that, in my mind, sort of misunderstands the diagnosis of addiction. Addiction is not about a physical relationship with the drug. It's about an emotional relationship with the drug and how that emotional relationship shapes their lives. Some of you have had the fortunate experience of interacting with patients who've been on methadone for a while and have gotten on with their lives. They've gotten to work. They've gotten their rights restored. They are successful parents. They're successful grandparents. And their use of medication is much like a diabetic's use of medication, or somebody that has high blood pressure. Their use of medication, it stabilizes their condition and they get on with life. And so that really is the measure. It's not whether they're taking a medication or not. It's what's going on in life. And it's a lot like what Philip was talking about earlier. This is a recovery-oriented system of care, or at least should be. Moving along, here is an elaboration of the data about methadone's effectiveness and so forth and so on. It's hard to make a negative case other than you don't like the medication. But in terms of outcomes, you get a lot of very robust outcomes. You get a lot of bang for your buck. From a criminal justice perspective, this was a study done back in the 1970s. You can see there was about 6 clinics in the northeastern part of the United States, and you can see a reduction in criminal behavior. Some of you may remember that it was the Nixon administration that nationalized the methadone treatment industry, basically to push the funding through Congress and the rules through the various rulemaking things to make methadone a nationally available modality, and they basically did that as a response to street crime and the effectiveness of methadone treatment in reducing criminal behavior, a lot of which at that particular time and still is associated with untreated opioid dependence. And this is that more results from that same study, John Ball and Alan Ross's study, where you see this sort of high probability of return to opioid. It's not 100%, but a high probability of return to opioid dependence when people got out of treatment. So getting people off of methadone is not the issue. It's how they function once they're off methadone. Getting people into opioid treatment programs, that's what OTT stands for, can be a great challenge, particularly in rural areas in the United States. So let me put this map up here, and you can see this is a map of where methadone treatment clinics were or are today. But you can see there's a lot of empty spaces on the map, and there's particularly a lot of empty spaces in the less densely populated areas. And paradoxically, those less populated areas, those rural areas, are today the sites of a burgeoning increase in prescription opioid abuse, and as is true in our state, and I suspect true in many other states, followed closely on its heels by heroin addiction in those same areas where people were getting strung out on OxyContin and Percodan and Vicodin. Now criminal syndicates have found willing customers for the purchase of heroin. So trying to get somebody into a methadone clinic can be very difficult based on geography, which is one of the primary reasons for the Drug Abuse Treatment Act of 2000, which basically made buprenorphine, particularly in the form of buprenorphine combined with naloxone, some of you know it as Suboxone, available not just through clinics but through physicians. So back in 2000, the Congress of the United States said we need to expand treatment options. We need to make medication-assisted treatment for opioid dependence more geographically available. We may need to make it available through physicians so that it's possible to have it in the general health care system, because in many cases the primary care physician is the perfect person to intervene with somebody, particularly someone who is early on in their opioid dependence career. Think of that 18, 19, 20-year-old that's been doing OxyContin for 6, 8, 10 months. This might be a perfect medication within the context of a physician's office to do that kind of treatment. So the purpose of the act was to expand treatment and to have another medication. You know, if you think about depression, another chronic medical disorder, we'd be not in as good a shape as a society if we had only one type of antidepressant. And so the issue is to try to expand the number of tools that physicians and their patients can use to treat, in this case, opioid addiction. To be eligible for prescribing Suboxone or Subutex, you've got to be licensed as a physician. That means a medical doctor or a doctor of osteopathy. Mid-level practitioners, nurse practitioners or PAs cannot prescribe this medication. Once they go through a 6 or 8 hour training, they apply to the DEA, they get a amended license, and they're allowed to treat 30 patients in their practice in the first year, and then can ask for an expansion to 100 patients in the second year, and every year thereafter. The advantage of using a partial agonist is that it, while it occupies the receptor site, it does it less robustly, and it doesn't get to the point of it's very, very, very difficult to die of a buprenorphine overdose. Most if not all of the overdoses that have been recorded have been in combination with benzodiazepines. It's a relatively effective blockade, and it's a highly effective medication. I've talked about these already, and I'll move along to the next slide. The disadvantages are that the cost of services, the cost of the medication itself, some insurance plans pay, some don't. Some Medicaid services pay for it, some others don't. Some limit the amount of time that a patient can be on buprenorphine and so forth and so on. You also have to screen for it specifically in urinalysis test. If you were doing, let's say, a dipstick or point-of-service urinalysis test, unless you were looking specifically for buprenorphine, you wouldn't find it there. And so sometimes that is an issue in criminal justice settings where they're trying to monitor their patients for misuse or re-addiction. The big difference between physician-based and clinic-based treatment is that physicians have guidelines, and some have requirements for urinalysis and require people to be involved in counseling and fellowship support groups. Other physicians don't so much. Whereas clinic-based services such as methadone, they have a variety of state and federal regulations that dictate an array of ancillary services and counseling as well. So you can see the number of buprenorphine physicians, waivered physicians that are available. That it's much larger than the number of opioid treatment programs. But one of the big issues is how to get that poor person who might respond favorably to buprenorphine into some kind of funded services. And the last thing that I want to say here before we open the floor up for questions and comments is that this is medication-assisted treatment. No one should ever think that this is just medication alone. That if you think about what happens in the course of addiction, there's a downregulation of this area of the brain called the prefrontal cortex, and that's the site of impulse control. That's our executive function. None of these medications really has a role in restoring executive function. It is only cognitive behavioral therapies that have been demonstrated to help rebuild that impulse control that's going to be necessary, not just to achieve abstinence, but to sustain it over time. Here are the issues that all of us face. Who's going to pay for the medication? Methadone, relatively inexpensive. Buprenorphine, more expensive. In court situations, who's going to be the prescriber of the medication? Are there prescribers in your area who are willing to take on these patients? Some folks some courts that I'm aware of want people to get buprenorphine, but they struggle trying to get that patient addiction counseling because some of the addiction counseling agencies in the area are not particularly comfortable with accepting patients who are on medication-assisted treatment. And then last but not least, this whole idea of case management, helping the person stay compliant, see the doctor, see counselors, and so forth and so on. So I'm going to stop here and just put up here are the resources where you can find the list of providers. You can find out more about Vivitrol from these various resources here, and then here are the various public access, the tip number 40 about buprenorphine and tip 43 about medication-assisted treatment. It's largely about methadone and so forth and so on. And I'm turning it back over to, I think, Alexa?
Yes. Great. Thank you very much, and thanks to both our presenters for providing us with a lot of information. We do have a few minutes left for questions, about 10 minutes, so I want to encourage everyone to ask questions that may have occurred to them while they were listening to our presenters, and you can type a question into the Q&A panel, which is, again, on the bottom right-hand corner of your screen, if there's something that you would like for the presenters to address. So again, please ask a few questions, and I'm going to go ahead and start to sift through them. A question, I think, back on the first part of the presentation related to the recovery-oriented systems of care. The person was asking whether there are any examples or good models on sort of the city or county level for criminal justice agencies that may be applying that model.
This is Phil. Well, there's Illinois. The model program here is the Sheridan Correctional Center, which has a pre- and post-treatment component to it. So we do the treatment inside and then community case management once a person leaves. And it's all based on a ROSC model, Recovery-Oriented Systems of Care. And then I was kind of scrolling through the questions, and they apparently recognized some of the material that I presented as coming out of Philadelphia. They were probably one of the groundbreakers around the recovery management thing. They actually did some very unique things with regard to funding recovery management. Those peer support people, these were actually people in recovery who, I'm not quite sure how the selection process was done, but the Philadelphia apparently came up with some funding to actually pay these recovery coaches to assist people, who are on a drug court probation and act as their recovery coach. So those are two models or two programs that I can think of that have fully operationalized a recovery management process.
This is Holly. If I could just add that both the GLA ATTC and the Northeast ATTC, in which Philadelphia is a city in our region, have published quite a few monographs and reports on ROSC, which you can download for free from the ATTC website. So you can visit the ATTC website, search for recovery supports, and a variety of monographs describe ROSC and the different components and the peer supports in particular. There was one monograph dedicated to that, and you can download that all for free.
Great. Thank you, Holly. While we're on that question, another question came through about, this move away from using 12-step and some of those other voluntary unpaid models. If you have the information about who is paying for what when it comes to peer services. Are insurance companies paying? Is there public funding available? State general funding? If you could give a sense for some of those issues.
Well, again, I'll just speak to what I know happened in Illinois. One of the funding opportunities around peer support services that came with Sheridan was the funding of the Winter Circle, which is a peer support group for ex-offenders, where TASC actually went and trained facilitators. Because Winter Circle is similar to a 12-step model, but it is a professionally facilitated group. Because there needed to be some controls around, things not getting out of hand, that kind of stuff. But anyway, there was some funding opportunities for the Winter Circle that came through the federal government as part of our Sheridan model. And then there was also some funding through, I want to say it was the Bureau of Justice. I'd have to go and check my notes, where they also made sure that the money was available for community support initiatives through, I'm at a loss for the title of the program. It'll come to me in a minute.
I will say, the grants that are funded as part of Second Chance Act,
right.
Some of the sort of recommendations or allowable uses of funding include recovery support services. And I even think there's some states that will put money into it, as well as a couple of insurance companies I've heard have now moved
right.
towards supporting
the other
services.
the other program I was thinking about was called CSACs, which were Community Support Advisory Councils. And so there had been some federal funding where different CSACs started up. We have two here in Illinois, one in the northern part of the state, one in the southern part of the state. And again, those were federal dollars that were available for clinical reentry based on, evidence-based practices that you need community case management and support in order to, reduce recidivism and improve outcomes for your programs. So the money is out there. You just have to kind of really look for it.
Yep. So a question about medication and that part of the presentation, about whether there's specific research or how strong is the evidence for effectiveness of Suboxone with probation or parole populations.
Well, the literature about Suboxone with criminal justice populations is not as robust as Methadone is. But there is a little, and you should also look at the National Association of Drug Court Professionals who have a position statement about the use of medication-assisted treatment in CJ settings. So if you Googled NADCP, you can see that position statement, and they also have a brochure that outlines the various studies relating to Suboxone in criminal justice situations.
Okay, thank you for that. That actually answers another question that we got, sort of asking generally how accepting the court has been in various states with the use of medication as a treatment option.
Well, it depends. I mean, there are some courts that are very open to the use of all medications. I'm fortunate here in Seattle, King County, Washington, is that methadone treatment's been part of our drug court for decades, and it's so well accepted that the court will actually be the payer of last resort. In other words, if Ron is going to drug court and he can't get funding for his methadone treatment anywhere else, they'll pay for it. But the other end of the spectrum is that there are courts that say that they won't even accept somebody who's already in methadone treatment, that they're going to have to get off of methadone treatment in order to be able to participate in drug court. So it's sort of all over the map relating to methadone. Some courts seem to be more open to Suboxone than methadone, so that's a variant. The use of sustained or extended release naltrexone, the injectable Vivitrol, seems to be spreading in criminal justice situations, and there's, I think, pretty sporadic use of disulfiram and acamprosate.
Okay. While we're on the topic of Suboxone, a question came through about concern with some of the drug court clients are abusing Suboxone. And the question is, what would be the payoff in abusing Suboxone?
Well, for a non-tolerant individual, they would get an opioid-like effect, which some people find useful, but they're not. If they're spending their money on Suboxone, I'm not sure why they're spending it on Suboxone, and if they're trying to get an opioid effect because there are more robust or powerful opioids out there available on the street. What people who are coming into my treatment center, and I know this is true because I've read the epidemiology studies from other parts of the U.S., is that the most common use of buprenorphine on the street, people buying it on the street, is to try to offset opioid withdrawal. That it's a really good detoxification medication, and so that would be the attraction, is that they're trying to self-detoxify or at least suppress the withdrawal symptoms that they're going through.
Okay. A question about starting a medication before release from prison. Is there sort of a prescribed or set time before release that one would start methadone or buprenorphine for opiate addiction or naltrexone for alcohol addiction?
Well, that's really a progressive question. I'm not aware of many prisons that will start people on medication before they release them from custody. But if I were king of the world and doing this, I'd probably start them somewhere around a month or two before their release date, but at the same time making sure that they were linked up for coordinated care upon release, that starting them only to release them to an environment where they couldn't get the continuation of the care that was started in prison would be an abomination. I mean, that would be just the worst thing that you could do.
Let me just kind of camp on to that. Also, soon, I'm not sure how soon, Texas Christian University should be releasing some research. They are actually doing just that. They've got a small control group in one or two of the prisons here in Illinois where they're going to start people on Suboxone before they're released. But the study is less than a year old, so I know they probably don't have much published right now. But if you go to tcu.edu, Dr. Kevin Knight is the lead researcher on that study, so keep an eye out for some data, hopefully.
Great. I do believe there are. Oh, sorry. Go ahead, Holly.
No, I was just going to point out that we have heard this in several other trainings that we've done. So although there's not much out there on it, there's a lot of buzz around it, actually, throughout the region.
Well, it'd be a great thing, I mean, because the methadone rules, for example, allow us to readmit somebody to admit somebody to methadone treatment after release from incarceration for up to 6 months after they've been released, with the idea that we would put them on methadone to prevent their relapse to heroin, so they wouldn't be out there using unknown amounts of drug and using contaminated syringes, being at risk for contracting hepatitis C or HIV.
Great. And for those of you that are still on the phone, I do want to encourage you, you now have the email addresses for our presenters, the ATTC network website. You also have the National Reentry Resource Center website. These are all places where you can access more information if you're interested in the Reentry Resource Center site as well as the ATTC. I know we'll be posting more information over the next couple of weeks in response to this webinar. With that, it is now 3:30, and I want to honor our commitment to have the webinars be an hour and a half. I know people need to move on with their days, so again, just want to thank our presenters for joining us today. Thank all of you for attending and participating, and of course, thank you to the Bureau of Justice Assistance for sponsoring this event. With that, this will conclude our webinar. A recording of the presentation and slides will be available online in the next few days on our website at www.nationalreentryresourcecenter.org. Thank you very much, and enjoy the rest of your day.